So we have Dr. Nidhi Mehta, who is consultant and HOD of Department of Transfusion Medicine at Nanavati Super Speciality Hospital, Mumbai. She is past achievement. She was Chief of Laboratory and Transfusion Services at MCGM, Thalassemia Pediatric Hematology, Oncology and BMT Center. Also, ex-consultant transfusion medicine at Kokila Bain. Passionate for therapeutic procedures and FRSs and special interest in developing and supporting softwares and procedures. She loves teaching. In fact, more than 140 talks in international and national events. We can't wait to hear you, madam. Over to you.
So thank you, Kaho. And I loved listening to Dr. Pradeep. It was a wonderful presentation and intriguing thoughts. And obviously, it's a learning for students. But yeah, for me, I don't have to talk about diagnosis. So I'll start. I have worked in a comprehensive thalassemia care center for last 5 years and have supported more than 350 transplants, more than 300 transplants, and I was collecting and harvesting peripheral blood stem cells. I have harvested from young, minimum 8 kg weight child up till 100 kg adults, and most of the all the collections were for only pediatric BMTs ranging from benign to malignant disorders and obviously thalassemia as well. So as Dr. Pradeep has mentioned, yeah, India is the capital for thalassemia. We have a huge burden of hemoglobinopathies, and the maximum is of thalassemia. How do I change this? Yeah. Yeah. So types of thalassemia need not to speak. I'm sure the audience here is aware. And the cornerstone of management is blood transfusion. And introduction of regular blood transfusions transform the thalassemia major from a fatal childhood disorder into a chronic disorder. Other options for treatment are hematopoietic stem cell transplants. BMT can offer a complete and permanent cure to beta thalassemia patients, including no need for blood transfusions. And I have witnessed all such cases. I remember a small little girl, blood group AB negative, for whom we used to struggle to, get AB negative blood because AB negative is the rarest. And she was transplanted and at the age of 2 years. And we were so happy and excited that she received no more transfusions. She used to come for follow-up, but a happy girl. Other options, gene therapy. So FDA has approved it, but it is two-way costly to even think of. But yeah, people are going for it. So what happens actually in thalassemia? Just a second. So safe blood transfusion is the answer. But that still remains a major problem in India. Contributing factors for delay in blood supply are difficulties in maintaining adequate blood inventory. There's a lack of National Blood Act and fragmented blood transfusion services all over. The other bigger problem is all the blood centers are not equipped well for alloantibody detection, which is a common problem. And of course, extended red cell antigen typing. So ideally, as in when the patient is diagnosed, the baseline RHKL typing should be done. In fact, the whole phenotyping should be done so that with multiple transfusions, if at all patient develops antibodies, he can be given a antigen negative blood. And the blood should be ideally obtained from voluntary non-remunerated blood donors. It should be processed, stored, and distributed by a center with valid license. And leukoreduced PRBCs are preferred wherever facilities available. Still a far-fetched dream for our country to have 100% leukoreduced blood products. So before embarking upon the management things of thalassemia, let me just give you a transfusion story of a patient whom I interact every now and then. She's a regular patient, and I have been part of transfusion for patients right from the age of 6 months till 45 years and so on. The eldest patient is 49 years, who I know. So this particular girl, as I know her well, at the diagnosis, it was 1 unit of blood. Initially, it was 200 ml and then it increased. By the time she was 3 years, she needed 2 full units every 2 months. She was growing and blood requirements increased. By the age of 4, she needed blood every 6 weeks. That is, when kids become playful, they run around, the requirement increases. By the age of 6 months, every 6 years, every month, blood transfusion was there. High school, when there's a study load, sports, everything, blood requirements every 3 weeks. By mid-20s, every other week. And by the age of 45 years old, she had consumed more than 1,500 units of blood. So that's the kind of burden on blood services and on the patients to, manage and get transfusions in safe settings. So the role of blood transfusion, red blood cell transfusion, is huge, and it helps in management of anemia. It controls ineffective erythropoiesis and improves oxygen support. So, as you all are aware, beta thalassemia is by beta globin chain, so I don't need to speak about it. So, primary management is of severe anemia and control ineffective erythropoiesis. I think I can. Ineffective erythropoiesis, distinctive and principal characteristic of beta thalassemia, leads to anemia and massive bone marrow hyperplasia. The alpha globin chains aggregate in developing red blood cells due to globin deficiency, and 60 to 80% of progenitors die at the polychromatophilic stage. So erythropoietin-driven expansion of erythroid precursors shorten the red cell survival, and it causes hepatosplenomegaly, elevated basal metabolism, extramedullary hematopoietic masses, skeletal deformities of face and skull, and fragile bones, which we all see in our day-to-day practice. So concurrently, it suppresses production of hepticity, leads to increased dietary iron absorption, and releases iron from the body stores. So hemoglobin threshold should be such which suppresses ineffective erythropoiesis. So it is required to improve the oxygen support. So mutations affecting the beta globin chain, which lead to either an absence of beta globin chain or variable reduction, result in anemia as well as abnormal hemoglobin composition. And HbA is reduced or absent, as we are aware of it. So predominance of HbF, and HbF has a nature of binding oxygen. It has high affinity oxygen in red cells. So becomes oxygen delivery becomes less efficient. Compared with other transfusion-dependent anemias, individuals with thalassemia can become asymptomatic with fatigue at higher hemoglobin level and display an increase in bone marrow activity. Individual differences in adaptation to anemia are due to variability in hemoglobin compositions and other factors. So challenges in developing transfusion recommendations for thalassemia. So we need appropriate recommendations, but there are multiple challenges. So focus should be management of thalassemia, health-related quality of life throughout the lifespan, and transfusion practices during childhood may impact the prevalence of bone disease and chronic pain in the aging adult patients. It is also likely that extending chronic transfusions to many patients with thalassemia intermedia will lead to better long-term quality of life. So there should be distinctive transfusion thresholds and goals in thalassemia compared with other transfusion-dependent anemias. At times, there is underutilization of blood transfusion in thalassemia. So what should be the guideline or goals? So many factors influence individual response to anemia apart from the hemoglobin level. This introduces complexity in developing uniform guidelines. But in 2016, AABB Red Cell Guideline recommends a hemoglobin threshold of 7 to 8 gram minimum. Specifically, do not apply to chronic transfusion-dependent anemias. So that should be not linked to thalassemias. So what should be the benchmark to judge the success of transfusion therapy? Red cell transfusions can sustain normal physical appearance, growth, and activity in children with thalassemia through the reversal of anemia and marrow hyperplasia. And the adults can achieve normal functioning in the professional and personal spheres. Somebody is a banker, somebody is a media personality, somebody is, running a jewelry store. So they should have a normal life. So why do I say underutilization? Because there are improper targets and absence of appropriate guidelines, and people try to minimize or take less transfusions, which can lead to persistence of symptomatic anemias and bone marrow hyperplasia. At times there's over transfusion, which is also a risk, but this appears to be much less. Transfusion guidelines with thalassemia should identify barriers and provide solutions to educate the providers, that is the clinicians, the pediatricians, and the patients as well. Iron loading instead of anemia is the most important management issue. So anemia is one major issue, and we should be maintaining adequate hemoglobin levels. And the other major issue is iron overloading, and then the donor exposure, which can lead to multiple adverse events, which the triple H and the other things. So coming to heterogeneity of transfusion-dependent thalassemia, we know the thalassemia is either TDT or non-TDT, NTDT, which may at times in later age becomes TDT. So beta thalassemia major caused by too severe, this we know. So children usually become symptomatic in the first year of life. Usually 2.5 to 3 months, mothers are very proactive, and they get their children with, less movements or lethargy or excessive sleepiness. In the severe beta thalassemia anemia, these patients may require intermittent transfusions during infancy, such as during an illness, or institution of regular transfusions often delayed until 3 years or later. In subgroup of thalassemia intermediate, transfusions are started in adult life in response to deteriorating quality of life or development of a complication from severe anemia. So guidelines till 2023, where we didn't have our own guidelines, we were working with the guidelines published by Thalassemia International Federation. But recently, Indian Academy of Pediatrics PHO chapter published the guidelines, which was a multidisciplinary effort, which included, counselors and psychiatrists, transfusion medicine specialists, and many pediatricians who contributed to it. So there has been a decline of splenectomy in thalassemia with the advent, which has a significant impact on transfusion management. Association between higher pre-transfusion HB levels and decrease in the rate of splenectomy has been documented. This supports the clinical observation that development of splenomegaly in thalassemia is the consequence of maintaining low hemoglobin. So aiming for low pre-transfusion hemoglobin can be counterproductive, as it promotes splenic enlargement with secondary rise in transfusion needs. So caution is needed when referring to older transfusion guidelines developed in an era when most adults with thalassemia were splenectomized. But in my practice, the elderly children, they are elderly children as in the patients who are 45 and plus, they are splenectomized. But the patients who are with the age group of 10 to 20, they are not, because transfusion is appropriately maintained. Advances in iron chelation therapy has also supported a lot. Transfusional iron overload is a major complication, and the iron loading rate also affects the efficacy of chelation. So initially, when oral agents were not available, only desferoxamine with the name of Desferal were available, and it was very difficult to use and had significant toxicity. So these concerns were very influencing to develop the guidelines. So management of iron overload became easy with the availability of oral chelators, that is desferasirox, which is available with the name of Asunra, and deferipone, which is available with the name of Kelfer 500, and the other novel chelation regimes. I would not go into the details. In current practice, transfusion volume and frequency should be selected based on the need to correct anemia and suppress the marrow hyperplasia. So transfusion recommendations. So ever since it was recognized that regular blood transfusions prolong the survival of children, there were efforts to identify patients who should be placed on transfusion. So additional concerns were creating safe transfusion practices in individuals projected to have a normal life expectancy. So the basic things are optimum hemoglobin target and specification of RBC units. And we need to have the indications to start regular transfusions. What should be the target, the volume of transfusion, the rate of transfusion, type of RBC product, and extended matching for red blood cell antigens. So when to start? So decision to initiate transfusion attempts to balance consequences from anemia and ineffective erythropoiesis against complications of chronic transfusion therapy. Early access to specialty care is essential so that the decision to commence transfusions can be made at appropriate time to support normal growth and development. And patients who are identified through newborn screening have care established before the development of severe symptoms. The time to initiation of transfusion is expected to be shorter. So goal of effective transfusion regime is prevention of splenomegaly, as I already said. So hemoglobin less than 7 on 2 occasions, at least 2 weeks apart, is the indication to start the transfusion. Hemoglobin more than 7 with one or more of the following symptoms, that is growth delay, infants less than 2 years, failure to gain weight for 3 months without any other etiology. Children, height velocity is less than 3 centimeters per year. Delayed onset of puberty, more than 12 years in females and more than 13 years in females are the indications. Skeletal facial changes, which are subjective photographic record, discussed with patient and family, splenomegaly, spleen more than 6, or enlargement more than 1 centimeter year after 2 years of age. Extramedullary hematopoiesis, symptomatic or moderate to severe ineffective erythropoiesis. Cerebrovascular overt stroke, silent infarcts, arterial narrowing, venous thromboembolism, pulmonary hypertension, osteoporotic fracture, poor quality of life in adults, decline in capacity to work. So the target to balance improvement in anemia and ineffective erythropoiesis with transfusional iron overload. Adequate pre-transfusion hemoglobin was initially estimated improvement in growth and activity in young children. Regimens maintained hemoglobin above 9 or 9.5. Children respond well with mean pre-transfusion hemoglobins of 10 grams per deciliter and a range of 9.5 to 10.5, which prevents splenic enlargement and skeletal changes while promoting normal growth. Patients who experience significant fatigue or skeletal pain toward the end of transfusion cycle may benefit from a higher hemoglobin. So whenever we are planning for a child to be undergoing bone marrow transplant or a hematopoietic stem cell transplant, we target the hemoglobins between 10 to 12. So volume of blood transfused is influenced by interval between transfusions, with those on 4-week schedule receiving a larger volume compared with those on 3-week to attain a similar pre-transfusion hemoglobin target. Transfusion volume also depends upon the type of storage solution. Since red cell units stored in additive solution have lower hematocrit, so it's always preferred to have CPDA bags. But nowadays, because to increase the life of the cells, mostly blood banks are using additive solutions. The effect of pre-transfusion hemoglobin target on the transfusion volume is not clear. Splenectomy is no longer a frequent procedure. Maintaining a higher hemoglobin can reduce the intravascular volume to allow a greater post-transfusion hemoglobin increment from a unit of RBC. So now coming to the specific guidelines, what we have. So pre-transfusion hemoglobin of 10 ranging from 9.5 to 10.5. In E-beta thalassemia, a range of 9 to 10. Frequency every 3 weeks in most older children and adults with B-thal major. Every 4 weeks in younger children, most children and adults with E-beta thal. It is preferable to change the volume of blood instead of the interval of transfusion to maintain hemoglobin target. So how you decide on the volume? In children, the transfusion is 4 ml per kg per gram increase in hemoglobin desired. The calculation uses transfusion hemoglobin of 13 grams per deciliter on 3-week and 14 grams per deciliter on 4-week schedule. In adults, 2, 3, or 4 units per transfusion. Generally, 3 units if pre-transfusion hemoglobin is less than 10, and 2 units if pre-transfusion hemoglobin is more than 10. Volume of transfusion at a single visit should be not exceeding 20 ml per kg. Other volume considerations: patients with intact spleen have higher transfusion needs, but splenectomy is not recommended unless under exceptional circumstances. Adult with body weight more than 60 kg may need 4 units on some transfusions, but that is case to case basis decision taken by the clinician. Higher hemoglobin target or transfusion more frequent than every 3 weeks are needed in rare circumstances, say in CHF and pulmonary hypertension, wherein you can not give more volumes, symptomatic extramedullary hematopoiesis, and occurrence of fatigue or bone pain in pre-transfusion period. Now coming to rate of transfusion, in children the rate should be 5 ml per kg per hour. In adults it can be 200 to 300 ml per hour, but ideally a unit of bag should be transfused within 2 to 2.5 hours until unless there are specific indications on giving low rates, which is CHF. Extended matching is a very, very important thing. We need to prevent red cell aluminization, and it should be the goal of any transfusion management in any patients. So ideally, before starting the transfusion, the clinician, the pediatrician should write the prescription and get the extended phenotyping done, so that in case there is any occasion when with multiple transfusions patients develop antibodies, this can be given an antigen negative blood. And of that, most common allo antibodies are anti-RH and anti-KEL. So universal provision of RH-KEL matched blood is ideal for any thalassemia patient. So type of RBC product, leukoreduced is ideal because to prevent febrile non-hemolytic transfusion reaction. As I said, with the active solutions, the hematocrit is 55 to 60%. But with CPTA, the hematocrit is high. But nowadays, getting CPTA blood is not that easy. Maybe in the standalone blood banks you may get, but in the higher centers, everybody uses blood in the solutions only. Age of unit of cell, the PRBC, is very, very important. It should be ideally less than 2 weeks wherever possible, and fresher the better. But yeah, not within 48 hours of collection. Washed RBCs has been replaced with leukoreduced, but yeah, in case patients have severe allergic reactions or there's a history of severe allergic reactions, in those cases, washed RBC can play a major role. Irradiation of RBC units is unnecessary unless patient is planned for BMT. So if the patient is already targeted for BMT 6 months prior to the date of transplant, the units whichever are transferred should be irradiated. Otherwise, universal irradiation is not indicated, and obviously during transplant and immediate post-transplant period, irradiation of RBCs is necessary. Phenotypic matching, recommended minimum antigen matching, and patients lacking LA antibody match to RH-KEL and have one or more antibodies match to whichever antigen or antibodies available. So other recommendations, it should be directly supervised by a hematologist with expertise in thalassemia, because what happens is when these children, they grow up, they would go to, any other hospital nearby their residence and take transfusions. And there's a usual feeling that, we have been taking transfusion. Even the family feels that, we are more knowledgeable, and they would not even consult a physician. They would just simply keep taking transfusions and CalFers on their own. So it is advisable that they are always supervised, if not every episode, at least once a month or twice, once in 2 months, they take a consult and check on the CBCs. Options for stem cell transplant should be discussed as soon as the diagnosis has happened, and the couple should be counseled for second or for the pregnancies. If they are planning, they can Obviously, the CVS for the new upcoming features should be done, and if they are aiming for transplant, they can be, preserving the cord cells for the transplant. Disease modifying therapies should be offered where appropriate. It is necessary to develop thalassemia specific protocols for patients receiving transfusions, ensuring optimal long term outcomes. And accurate record of transfusion should be maintained, which can be used to calculate annual transfusion requirement and iron loading rate. Development of iron overload should be evaluated with serial ferritin measurements at least once in 6 months. T2 star MRI should be done. Um, T2 star MRI for liver, and the cardiac MRI should be done to understand if there's any iron deposition. And patient receiving regular transfusions or intermittent also should be entered into a state level registry, which can be interlinked to develop a national database. This is very much lacking for our country, but I must comment here that the center with which I was working, we had 1,400 thalassemia patients registered for comprehensive care, and nearly 140 patients were registered for regular transfusion, and we were maintaining a nice record of all the investigations and the volume and the rate of transfusions being given. So, coming to the niche area where I work in blood banking, availability of blood components is a huge issue. National level estimation study was done in India last year, where a demand supply gap of 2.5 donations per thousand eligible person, which is around 1 million units, is still there. Last year on World Blood Donor Day, the health minister has released a notification that there's a requirement of 14.6 million units in India, and we are short by 1 million units. The gap emphasizes the need for sustained and concerted efforts from all stakeholders and for increasing awareness about the repeat voluntary non-remunerated blood donors. So, what are the barriers to voluntary blood donation? Misinformation in the donor population, lack of motivation, inability to access the blood donation center due to maybe busy working schedule. Today only I got a call from someone, we needed A negative, and the donor says that he can come only on Sunday. But usually Sundays, the corporate hospital blood donation centers, they don't work. So, I mean, then we motivated them and made him come at 5 p.m. Maybe fear of bad health after donation, family discouragement. Mothers are a big factor who would, tell their sons and daughters not to go and donate, thinking that, something will happen. But this is usually not the case. So, family should be encouraging for the children to donate, because nowadays many of the colleges, in fact NSS, they do a lot of blood donation camps. So mostly blood donors are one-time donors in India. There's an absence of national blood donor registry, and nowadays with frequent relocations, voluntary donors also tend to move, so it's very difficult to retain the donors, though with the softwares and many sites, donor database can be accessed on the e-Rakt Kosh. One plus point is we have national blood policy, but still, despite of that, we have several challenges in our country to ensure the availability. That is absence of National Blood Act, inadequate financial support to the blood banks, blood centers, poor infrastructure, substandard quality assessment system, and a lack of integrated information technology support and political willingness. Our PM Modi had showed political willingness. He started with e-Rakt Kosh, wherein all the blood centers are mandated to enter the data of collections and donors, and I hope that will help develop the availability in a better way. So, since regular blood transfusions remain the mainstay of management for thalassemia patients, it is important to ensure the blood inventory for patient care is sufficient and accessible. It is also essential to address unmet needs of transfusion with a collaborative approach in mitigating the gaps by defining priorities. And all stakeholders, that is, patients, blood bankers, clinicians, and the NGOs, should get involved in policy making, and feedback from patients must be considered to tailor future actions. So, this was the theme for the World Thalassemia Day: empowering lives, embracing progress, equitable and accessible thalassemia treatment for all. These are the references which I have used for preparing the talk, and obviously a lot of Google search and my own experience comes here. Thank you so much for patient listening, and I'll be happy to take any questions.
So thank you, Dr. Nidhi. And there are two questions. One is from Dr. Garima. She's asking, stem cell preservation, is it the solution to prevent or, thalassemia? And she asked it before also. So what's your take on that? Because you spoke about stem cell preservation.
So, stem cell preservation, I think she's asking about the cord blood stem cells. So,
Mhm.
that will not make much sense for thalassemia, that is for other disorders. But yeah, for, I mean, the second sibling is not having thalassemia. In those cases, the cells can be preserved, or cells can be collected from that child and transplanted on the first sibling.
Okay. I
And
hope, Garima, that answers. And there is one more question, Doctor, from Dr. Manoj. He's asking that please guide on automated washers available for RBC products for transfusion, because if we do it manually, there is a risk of contamination of the product.
so I'm not much aware of automated washers, but yeah, the washing of cells is mostly gone out of practice because of available of leucofilters. But in case saline washing has to be done, the bags can be connected with sterile connecting devices with the saline, and this procedure can be repeated thrice. So, doing it under laminar flow and with sterile connecting device may help reduce the chances of infection.
Hope that answers the question. There is one more question in the chat box. Why should we not give blood in less than 48 hours to THAL patients?
Uh, I I am not able to understand the
Hmm.
question. Means
The question, I think, is if there is a THAL patient and we are giving a transfusion today, is there, the question is, in 48 hours of the first transfusion, why we should not give it to the patient who is thalassemia? I hope my question is correct, Mr. Baki Karunakar. Yeah.
I'm I
Can
think
you just put the question again in a much simpler way so that we can get the answer from our expert? Okay.
thalassemia. I
Mm.
can see a question from Chandrakala. So, thalassemia minor may require transfusions anytime, and I have given transfusions to thalassemia minor when the usually in minors the hemoglobin ranges between 8 to 9 or sometimes 10 also. But if the hemoglobin goes below 7, and if there's any clinical scenario or a surgical thing or any other thing, if there are more of instances of fatigue and breathlessness, then in those cases, thalassemia minors may need transfusions. But I am unable to understand the question. The question, what I understood is, at the interval of 48 hours, why should transfusion not be given? This can be only prohibited if there are clinical scenarios. Otherwise, nothing to my understanding as of now.
So, madam, thank you. There is one more thing which we are doing through Kehu and Roche, which is not a question but your inputs. It's a white paper on Roche has come up with a study where NAT testing in India. So, I think everybody from our healthcare division does agree about NAT testing, but is it possible in our country? I mean, how far are we from actually putting a rule that NAT testing should be there? That's number one. Number two, what do we do in emergency situations where there is a uh, requirement urgently? I mean, this is a question not, but it was in my mind because we are trying to do this through Roche.
So this is a very good initiative, and this should be done because when I see patients who become HIV or HCV positives, It is really painful. But one thing I would like to mention is the zero risk blood. The NAT people, what they claim that, blood becomes zero risk. So zero risk is only when you have no transfusions. But in case of thalassemia, that is not possible. So one thing is good history, the donor history questionnaire from the donor, and obviously NAT is helpful, but coming to 100% NAT testing in country is, again, I would say, a very, very far-fetched dream, because until unless government comes with the policy and there are hub and spoke models across country for testing, uh, this would not be possible. I mean, till date, I can say that only 10 to 15% units are tested, because say major corporate hospitals would have. Orissa, there's a model of hub and spoke. Karnataka, there's a model of hub and spoke. Delhi, it is there. But still, if we say Mumbai, it is from, individuals have collected together to get this testing done. But there is, until unless it comes from top, from the government, it will not happen, because the challenges of the costing is also too high.
Yes, I think very well said. And I would share the first draft of that white paper to you personally. You can have a look, and I think I'll put up these topics, whatever pointers, because all of us were concerned when once CAHO endorses that white paper, which is that NAT should be done. But again, there are concerns of hub and spoke. There should be union of all the blood banks trusting the corporates, because it will be a big hospital or a big corporate lab. And the costing, I think it's very, very important. And
To
we
add
are
to add to it, I would just share. I'm working with the corporate. My hospital, and we have guidelines from NBTC on a specific charging pattern. We cannot charge more than X. Now
exactly.
we can get the testing done, but what about the standalone centers? In Mumbai only, if you consider, there are so many private blood centers who are working day in day out, and they are collecting blood day in day out. In fact, they are paying to the organizers sporadically in terms of saying that infrastructural cost to organize a blood donation drive. But are they really able to test the units? If yes, okay, they are doing the testing. But are the clinicians agreeing to pay? The clinicians, they will like to use the stent which is the best, the drug delivery stent or whatever, but paying that extra cost on the unit of blood pains them.
Absolutely. I think I'm grateful to Barnali for one more thing, for getting me introduced to you on behalf of Kaho, because this is something which has been bothering me, and I am definitely going to share that first draft of that white paper with you, madam. And because we need to voice it properly, as you rightly said, and also address it with the clinical faculty, because just putting it across and not getting the NAT tested blood used also, because in your hospital I can understand, madam, as you rightly said, but if you're sitting somewhere in Palghar or Dadu, some tier 2 or 3 city, it's very, very difficult. It's very difficult.
It's really,
Um,
I
I
would
think
say it
there
is
is one,
impossible.
yeah, one more question coming from Garima. I think it's a repeat question. Does the stem cell preservation help in thalassemia?
So this is, I guess she's asking about cord stem cells. What I was talking about, cryopreservation of the stem cells which we collect. So what happens in a thalassemia patient where we are planning a transplant. Say for example, I just shared my experience of a AB negative patient for whom we transplanted. So she was given cells from her own sibling. Yeah, so cord stem cell will not help, from her own sibling. So what happens? This becomes a allogenic transplant. But at times it may so happen that the allogenic transplant will not function. There's a rejection for some reason. So what we do is, in such allogenic transplants, we always try to preserve autologous cells. So in case the marrow doesn't function, we have something to give to that patient to live. I mean, instead of experiencing rejection and causing the life, we have the autologous cells to be introduced. And sometimes in the allogenic cases also, maybe patient is not primed, or patient is not ready for transplant, if there is a donor available, we get the cells, cryopreserve the cells, keep it, make the patient ready and give it. But cryopreservation of cord stem cells from the sibling or own will not work much. Cord stem cell from the cord stem cell registry, if there's 100% match of the patient to the cord, it can be done.
Thank you, ma'am. Can we, it's a wonderful session of, yes, thank you. So we had wonderful interactions from our participants.